Something that certainly helped me is something that we've been using for a few years, and we found it to be very useful, is making and pre-operatively acrylic copings that will snap on to the temporary abutment. In this case, this is the carrier assembly that acts as a temporary. But Henry's done this quite often. I know you've been very successful doing it in single units and multiple unit cases. Could you tell us a little bit about utilizing acrylic copings and doing direct temporization?
Initially, to facilitate a protocol in the office where everybody can utilize this technique very easily, no matter which clinician in the office uses it, we've created a protocol that allows even the dental assistant to become a very integral part of this approach. And what we've done is create temporary copings, acrylic copings that pick up the margin of the abutment to be utilized, and to do this pre-operatively. So this way, once it's fitted on the abutment, all that has to happen is to lute a crown former to the acrylic coping, pick it up, fill in the voids, polish it, seal it, and you have a very easily made and very efficiently made temporary restoration. And this can be done by anybody in the office, any part of the staff.
This is a polycarbonate crown from GC, and we're just trying it in to see it fits over the temp base cap and that the contacts are reasonably good. And we're going to utilize that to make up the temporary. Just adding the acrylic to this now. Give me some liquid, Kimmy. This is just mixing the acrylic, and we're going to add that now into the polycarbonate crown. Give me a plastic instrument to do that. Not too watery a mix. Okay. And we just tamp it down gently into this, trying to avoid any air bubble inclusions. And not having it too liquid so that it flows down into the gap that might exist between the implant and the surrounding osseous. A little liquid. Let the acrylic volatilize. And now we just add to that. Wash it off to make sure we have no hemorrhage. And you can see this, as Maurice did it, we really have no hemorrhage to this. Now just index this into the optimal position. Now we just hold it there until it sets, and that will pick up the temp base cap. I'll then take that back into the lab and just fill in around the margins. Remember, the margin of the temp base cap accurately fits the head of the abutment, which was the carrier in this case. And then all I really have to do is shorten the incisal edge slightly, and we'll be fine. You can see this is just about set now, and what we're thinking about as we go through this process is your options. Remember, Maurice talked to you about doing this as a 4.5 and switching to a 3.8 or even smaller a platform. But we have another alternative in this situation, and that is to utilize this as a one-piece implant, meaning the carrier becomes the actual final abutment, and we don't have the need to take it off at any stage, so you effectively have changed a two-piece implant into a one-piece implant. And once we don't open that micro gap and we don't remove it and expose the micro gap, we have all the benefits of a one-piece implant. So we're going to try and do that in this particular case and see how it works out. Now that the acrylic's set, we can go ahead and remove this, and you'll see it should come out fairly readily, bringing the temp base cap with it. And you can see the margin now of the temp base cap. We'll wash this off, add acrylic in that little void there, and blend in the periphery of the temp base cap to the periphery of the tiny little carbonate crown, polycarbonate crown. And then we'll put it right back in, as you'll see, with just an antibiotic ointment, not risking placing any cement down at that gap. You can see now in the lab, what we've done is we've added acrylic from the margin of the temp base cap all the way through, joining up with the periphery of your polycarbonate crown. I'm just going to try this in now. We'll adjust it for occlusion, make any final adjustments to the aesthetics thereof, and then we'll just place it in with a little acromycin ointment. And these temp base caps fit rather nicely. You'll see it pops in and clicks into place. Drop your chin slightly. And now we'll just check the occlusion on that bite tight and grind around a little on this. Grind a little more, open. Give me a mirror. And you can see on the lower teeth already, as well as the upper, that she's touching, but we want to ensure that she's not touching this. And so I'm going to ease it very slightly. And that should do it. Close on that again and grind around. Great. And open. And one more touch and we should be fine. And close. And grind again. And open. And now we're sure that she has no contact at all, so this is really an unloaded temporary, and I'm going to shorten the incisal edge fractionally for her, and then we'll go in and put a sealer around the base. So this little top over here, so that we get no debris down the access, and then we'll cure this before putting on the temporary. Now we have the temporary ready, and I'm just going to fill that up with acromycin ointment or dentamycin ointment preferably. Just fill it all the way up. Give me a little more. And this is basically a little thermoplastic, so as I put it in, it becomes a little more gel-like. And then you'll get just the ointment coming out. And bite together for us. Suction the distal. And that's basically it. We've completed it. This is really total tooth replacement in one visit. We have the final impression on her, and at next visit, just suction the distal. Next visit, we will have the final restoration to place in position.
Because the tissue hasn't been disrupted, it has not been traumatized by an incision and a flap, actually allowing the lab now to proceed with the fabrication of a final all-ceramic crown to be placed in the mouth at 8 weeks. So really, we've taken the implant procedure from multiple procedures, multiple surgeries, an extended time frame, and now one procedure being able to immediately temporize, and in just a short while, in a couple of months, immediately proceed with a final restoration. That's the exciting thing of what we are looking at in the future. Having done quite a few of these now, and since I don't really do the restorative aspects, what would you both think about the maintenance of the soft tissues, the ability to immediately temporize? What has it done from the standpoint of aesthetics, maintaining the soft tissue that surrounds the extracted tooth versus having to reconstruct it later as we did classically with a two-stage approach?
I think one of the key issues is that we do preserve it. We preserve it in the exact state that it existed when the tooth was there. And this is key because we don't have to go through the usual process that most people will have to sculpting that tissue and developing that tissue and adding the tissue. The real key issue, of course, now is not to lose any of that tissue, to preserve it all in its existing form. And what we like to do, as we discussed in the video, is under-contour the tissue, negatively contour it in that subgingival arena so the tissue collapses somewhat. And we actually seem to end up with a little more tissue, not a little less tissue.
The big phase and the big emphasis that we've placed over in our protocol over the last 6 to 8 years was put an emphasis on protecting that labial plate of bone subsequent to implant placement. One of the things that we found is that placing the implant a little bit more palatally away from the labial plate of bone does a few things to facilitate that preservation. One, it allows the remodeling of the bone that takes place around the microgap, or the area where the implant restorative interface takes place. And so that remodeling can take place without actually affecting or resorbing that labial plate. So palatal placement, immediate provisionalization with a temporary that's under-contoured, or even a healing abutment, if that's the path that the clinician chooses for that day, that healing abutment also remains under-contoured to protect the soft tissue, to allow that soft tissue to remain in a more coronal position. If the implant is immediately loaded, there are several macrogeometric design aspects of the implant that the clinicians are moving towards that has to do with platform switching or utilizing a unibody implant. In essence, trying to minimize the effect of that microgap. Platform switching, in a simple sense, is utilizing a smaller diameter restorative component on a wider diameter implant and allowing for a horizontal shelf that allows the biologic width to take place a little bit closer to the center of the implant on a horizontal level rather than on the vertical surface of the implant. And that's been a big factor in also maintaining a higher level to the attachment apparatus, both in the bone and the soft tissue.
What we'll start to see in the future, and what Henry's saying, and David, is really the ability for us to protect the labial plate, protect the soft tissues, under contouring, placing the implant away from that area, which is so critical. And then, of course, in the future, looking at platform switching to maintain the vertical bone height, and possibly even a unibody or a single-piece implant where there's no longer a microgap between the restorative, the abutment, and the implant. And I think that those are all exciting avenues. We'll really need more and more research and follow-up over the next few years. But
I mean, for sure, the future has, with new imaging technology and new software, we can pre-plan the positioning of the implants and even pre-select final abutments to be placed at the time of implant placement. And we can scan the abutments, I believe, in the future and be able to go to a final restoration on the same day. In some selected ideal cases where we have good bone quality, excellent primary stabilization, and to be able to get good tissue integration at that particular time. So the future definitely is the marrying, if you will, of imaging technology with CAD/CAM technology, and to be able to do not only the implant placement the same day, but possibly even the final restorations.
And with the advent of the utilization of intra-office CAT scan technologies, which is going to be more and more of an issue as we're able to bring down the cost of this technology, having CAT scans available even for the single unit cases. And then, David, being able to not only have a precise surgical guide for the implant, allowing maybe even non-surgeons to be placing the implants, and then going to CAD/CAM technology, which is available right today. So some of the technology that Henry's mentioning and alluding to is available right now. It's just a matter of integrating it, making it less costly, and then really making it a standard protocol. I think that these are possible as we pay attention to the biology and don't disrupt what we've learned from the science of all this, as Henry spoke about earlier. There still is a science. The implants must be stable. The implants do have to have osseointegration occur, and that is a combination of biology. And of course, what we're talking about is the expedition of this treatment and being able to do it efficiently, cost effectively, and aesthetically.